Hello everyone, so we've just seen how to address the posterior leaflet with posterior leaflet prolapse. What happens when the prolapse is not directly in the posterior leaflet or anterior leaflet, but in the commissures? That sometimes can be somewhat vexing, both in the diagnostic approach to transesophageal echo to make the diagnosis, and surgeons never want to be surprised when they go to the OR and suddenly it's the commissure. But let's prepare how to manage commissural prolapse. So we're going to talk about two cases of how to reconstruct the commissures, either with Gore-Tex neocords, commissuroplasty, or a combination of both. Let's take a look. So now what happens if the pathology is not posterior, but in the commissure? These can be difficult to diagnose and even harder to repair because of the unsupported leaflet segments. This particular patient had endocarditis remotely, including a femoral embolus, made a full recovery, now presents with severe mitral insufficiency, requiring operative intervention. He also had a slightly depressed ejection fraction. Upon exposure and evaluation, one can appreciate the healed vegetation, which is resected, and the substantial amount of unsupported tissue. So you can see this involves the commissure and the majority of the beginning of P3. Now there's no active infection anywhere, and so in this situation, we elected to support this leaflet with neocords. For optimal durability, in lieu of a replacement, repair can be performed, but it's important in any repair to avoid the potential future complication of stenosis. Now, while a commissuroplasty alone, by bringing P3 to A3, could be done, given the size of the annulus, this patient was 46 years old, and I elected to give him the best chance at long-term durability. And therefore, we elected to first reconstruct in a stepwise fashion that's lesion-specific. The most predominant is where the vegetation and chordal loss occurred at the commissure and extending into P3. Gore-Tex cord was placed, the knot towers secured, and then a reassessment. We can see on reassessment that there is a very large cleft between P3 and the beginning of A3 with some tissue loss. In this situation, an abbreviated commissuroplasty with a single stitch is performed. And this is a simple figure of 8 done under pressurization so as not to make this too narrow. You can see this is nearly at the level of the annulus. And we've got the majority of the valve already repaired with one cord and that minor commissuroplasty. But you can see there's still some prolapse and tissue loss at the level of the proper P3. Therefore, a second cord is utilized to support P3. And a double loop technique, as previously demonstrated, will then support now P3. Given the fact that the anterior leaflet is relatively normal, we're able to create a very nice coaptation. And one can appreciate that the annular size remains fairly large. So therefore, in this 46-year-old gentleman with a overall weight of only 45 kilograms, we're able to
hopefully give him a durable long-term result, placing a 38 millimeter band and excellent coaptation for this commissural deficit. Without any residual mitral insufficiency, and no evidence of stenosis with a gradient of 1. Now, what about another case where we have commissural prolapse and flail? It's important to get the diagnosis correct by preoperative echo imaging, and sometimes this can be missed. It can be suspected to be posterior leaflet, but in fact, it is actually commissural, and this has to be done with a careful TEE image. 3D can assist by really looking at the jet direction, and if it crosses the coaptation point, one should start to suspect that even on 2D. So now we have a commissural prolapse and flail. Again, instead of simply putting a valvuloplasty alone, we're utilizing neocords to help resuspend this. In this case, given the non-robust nature of the papillary muscle head that feeds this area, I elected to use a single pledget but not tied to provide that anchor in presystole. A double loop technique was formed, and the commissure reduced. Now you can see that needed to be tightened some, so we're now going back and bringing up the loop to enable this to be delivered further, and then locked and tested it once again. And we have that fairly secure with just a minor supportive, in this case, horizontal mattress type of commissuroplasty, just to provide a little extra support to that commissure. Again, this avoids the running nature and allows the persistence of a nice orifice and placement of fairly large supportive band. Again, another a 38 millimeter. And demonstrating an intact repair without stenosis. And so these two cases demonstrate the possibilities of repairing commissural prolapse with appropriate planning.
Now we know how to address commissural prolapse. Building upon that, what happens when you actually have focal anterior leaflet flail? And that's going to be our next episode.